which comes from the University Clinic in Graz, will be presented by Dr. Mona Findeklee. Thank you so much for jumping in I know what... Excellent. Go ahead and you can get my...
Thank you very much. Test. Okay, I guess that's quite fine. So, good afternoon, everyone. My name is Mona Findeklee, and since I'm shortly stepped in for my dear colleague, I hope I can give justice to this presentation today. My focus will be on the advantage or the possible advantage of the new perfusion algorithm. So today I will be speaking about the impact of advanced metabolic brain perfusion in the differentiation of radionecrosis versus tumor recurrence and in the assessment and grading of astrocytomas. As this is a quite complex and I know somehow unwidely title, I've decided to divide my presentation into two parts. Starting with the differentiation of radionecrosis versus tumor recurrence, I briefly recap what some of you might have already heard last year by my dear colleague Dr. Altmann. Then I will illustrate our key concepts and then present our results to date. In the second part, I will introduce you into the assessment and grading of astrocytomas. I will provide some background information, then demonstrate our methods, and finally share our initial findings. So, let's start with the first part, the differentiation of radionecrosis versus tumor recurrence. The next 3 slides will be just a short resume of what my dear colleague already presented last year, so I'll keep this short. For a better understanding of the objectives, it's important to note that after therapy of glioblastomas, there is a phenomenon called pseudoprogression that can occur in some times. This mostly appears within the first 6 months after therapy, whereas a radiation necrosis or true tumor progress commonly manifests after this period of time. There's a peak approximately about 6 months to about 2 years. So, in common perfusion datasets, glioblastomas or tumor progress in common is associated with an increase in the CBV, whereas the aforementioned changes like pseudoprogression or radiation necrosis are linked to a decrease in the CBV. But currently, there are still no well-defined threshold values yet. For so far, we place great hope in this new and novel perfusion algorithm we are talking about the whole day. So let's fast forward. This is a short overview about these parameters we are talking all day, and of course a visible comparison between a commonly used perfusion map and the new ones by Sercare. And these are not only a great number of innovative parameters, they also are computed significantly faster, but I guess you all know this, so let's keep going on. Let's start with a short exemplary case. In September 2020, in September 2020, we can see this clear case of a tumor recurrence with a contrast enhancement here located near the left ventricle. And yes, in this area there was also seen a hyperperfusion in the Sercare perfusion map. Whereas we weren't able at the same time to see this hyperperfusion in our commonly used perfusion maps. Great. But it gets even better. When retrospectively, we can also see this hyperperfusion a month earlier in August 2020. So, suggesting that these new algorithms are capable of detecting tumor recurrence way earlier. So let's have a look at our study. Out of 409 patients screened between 2017 and 2024, we were able to include 53 patients according to the inclusion or exclusion criteria for exemplary with no adequate follow-up, of course, and we had also to exclude all patients with a broken early progress within the first 6 months, just to avoid including pseudoprogression by accident. And in addition, we received another 23 more patients from external study centers. So finally, we were able to have this cohort of 76 patients with all a confirmed diagnosis, histopathologically, of course. So, and here is an overview about our histology data. We've got 61 cases of tumor recurrence. We've got 15 cases of necrosis, while there are 17 cases of tumor recurrence and 6 cases of necrosis from the 3 external study centers, which all of them applied, of course, to the same inclusion criteria and imaging protocols. So then, at least 3 experienced radiologists, of course independently and blindly, evaluated the perfusion datasets and provide subjective assessment. And as you can see here, in the comparison between our commonly used Siemens dataset and the novel CERCAT dataset, here for example the CBV, we weren't able to find groundbreaking differences yet so far. Even the overall sensitivity was high. But fast forward, we were able to recognize significant differences in the objective analysis of these parameters in several parameters, like the here shown CMRO₂. Oh, where does it? Here, you can see it like in the CMRO₂, or we were able to find similar findings in the CBV, for example. So, here, come to our next step. There's an overview about the evaluation of our objective analysis, and as you can see here, in many previous high-quality studies, they are reported about sensitivity of about 80%, but we were able to achieve an excellent sensitivity of 93% in our objective analysis. And in addition, also our area under the curve of 0.87 further demonstrate that we will be capable of accurate identifying large proportion of tumors with these new algorithms. So, in summary, as I just said, the subjective comparison weren't groundbreaking, but our objective analysis promise that we can find parameters with these new algorithms to, validly find early progress in tumors. Of course, we need some further researchers, and we aim for a bigger cohort, but our currently findings were so highly promising that we already initiated several other studies, and so this leads me to my second part. So, now I'll introduce you into the assessment and grading of astrocytomas. Let's start with some background information. As you might all know, astrocytomas are classified into 4 grades by the WHO classification of 2021. And this classification has undergone several revisions until now. But still, the pathological confirmation still remains the gold standard. Imaging, of course, can provide some good and supportive information, but it's still not reliable sufficiently on its own. But in the clinical practice, for the concept of therapy, and especially for the prognosis of the patients, they are strongly dependent on the tumor grading. So there should be methods that are reliable and valid in pre-interventional tumor grading, especially for patients maybe with tumors in difficult-to-access locations, or patients, young or old, with tumors with low-grade astrocytomas. So we're searching for these safe options without the need of a surgical intervention. Let's have a look at our second study. We ultimately were able to include 60 patients out of an initial cohort of 403 people, screened between 2017 and 2025. We have included, of course, all people without a MRI perfusion data set, and we had to exclude everyone without a histologically confirmed diagnosis, including the WHO grading. Then we took all these 60 patients and their data sets and processed them with the CareCare software, and creating these beautiful CareCare perfusion maps. Then we placed some region of interests in subjective, highly perfused areas. In addition, we also placed some region of interests based on flare and contrast-enhanced T1 weighted maps covering the whole suspicious lesion. Because especially low-grade tumors do not necessarily exhibit contrast enhancement or hyperperfusion. And for comparison reason, we also placed some region of interest always in the contralateral healthy tissue. Then the software processed this data set as I show here, and first of all we found out the small region of interests were way less informative than the larger one was. So the larger region of interests were able to really find some significant changes in several parameters, as the CBV again, and I marked it, and also the CMRO₂. So that's the reason why our further studies focused on the larger region of interest. So move on. Before I just tell you what we've done next, I want to show you the distribution of tumor gradings within our cohort, because let's see, we've got 17 cases of grade 4 tumors. We got this large amount of 30 cases of grade 3 tumors. There were just 11 cases of grade 2 tumors and one and only one WHO classified grade 1 tumor. So that's the reason why we assume that this quite small cohort size, and especially the limited numbers within each tumor grade, prevented us from finding significant differences so far. However, when we're starting grouping these grades into a low-grade group, using grades 1 and 2, and a high-grade group using grades 3 and 4, we were able to merge some significant differences in several parameters. So these new perfusion algorithms are able to be processed and to find some, or to distinguish between these groups. And I know these are only preliminary findings for now, but of course we want to do some further researches, and we want to do some bigger researches. We're planning some multicentric studies to optimize and have way larger cohort sizes, because we believe that a substantially larger cohort size will confirm our preliminary findings, and further, maybe it will allow a differentiation, a significant differentiation within each tumor grade. So even these are just preliminary findings. We strongly believe that with new perfusion algorithms and new software models, we are able to help the clinical routine. We are able to find some reliable and valid methods for pre-interventional tumor grading. And this could be in particular beneficial for patients with, as I already told, tumors in unfavorable locations or patients with tumors suspected low-grade. And further, we also want to determine whether early de-differentiation of low-grade tumors can be detected, and if so, not all patients has to require immediate surgery, not at all cost, and even when, for example, a high-risk operation in the brainstem. So, I'm very honored that I could have been here today, and even without a great history of researches or papers done, and being the first year of my residency. And yes, I hope next year we can present you more than our preliminary findings and maybe some clinical relevant findings. Yes, thank you for your attention.
Thank you for doing such a great job presenting on such a short notice. Are there questions from the audience? Maybe I can ask you, so what do you hope to see or find in the work you will be doing from now on?
Yes, as I want to tell you, I want to try to find a valid way and a valid method for tumor grading, especially in this case in astrocytomas, because I guess it's a valuable opportunity for patients. I don't know, a young patient that is afraid of surgery, that we can tell him, oh, your tumor is just a low-grade tumor. You doesn't be afraid at all. We have some time. And I hope we can do this, because now all patients depend on surgery because they depend on the histopathological confirmation. We want to build up a valid and maybe in the future gold standard way to discriminate them. I think dreaming big is okay.
Thank you. That's a great ambition. Thank you so much.
Can I make a quick comment?
Oh, what's there? Oh,
that's me.
Sorry. Oh, I overlooked you.
No problem. Thank you very much again for presenting these results. Although I understand it's very preliminary, I just wanted to point out that it seemed like the CMRO₂ effect in the first study that you showed seemed particularly quite large, actually, for differentiating between radiation necrosis and glioblastoma. And that actually aligns very well with the study that came out from Lyon a few months ago, where they looked at the difference in CMRO₂ with progression and pseudo-progression, and in 2 different cohorts. And they also saw the quite impressively large CMRO₂ effect. So yes. I thought I would just point that out.
Thank you for that comment. Do you want to?
No, thank you.
Thank you.
But thank you very much, and good luck with your work.
Thank you.
Thank you.